Welcome. Today we're diving into a complex urinary system condition called Detrusor-sphincter dyssynergia, or DSD. This occurs when the bladder muscle and the urinary sphincter, which controls the flow of urine, don't work together harmoniously. Understanding DSD is crucial for proper diagnosis and effective management, which we will explore in detail. So, what causes this uncoordinated activity? The most common cause is neurological damage. This damage disrupts the normal communication pathways between the brain, spinal cord, and the bladder. Conditions that can lead to this include spinal cord injuries, multiple sclerosis, stroke, and certain congenital conditions like spina bifida. Rarely, DSD can occur without a clear underlying neurological cause, but these cases are much less frequent. Let's delve into the how of DSD. Normally, when the bladder fills, the detrusor muscle, the bladder's main muscle, contracts to expel urine. Simultaneously, the urinary sphincter relaxes to allow the urine to flow freely. In DSD, however, the detrusor muscle contracts while the sphincter either doesn't relax or, even worse, contracts too. This creates a high-pressure system within the bladder. The urine is forced against a closed or partially closed sphincter. This backflow of urine, or vesicoureteral reflux, can damage the kidneys over time. The increased pressure can also lead to bladder wall thickening and the formation of diverticula, or small pouches, in the bladder wall. The exact prevalence of DSD is difficult to determine because it often goes undiagnosed or is misdiagnosed as other bladder problems. It's most commonly seen in individuals with spinal cord injuries, affecting a significant percentage of that population. The incidence also varies depending on the underlying neurological condition. Due to limited widespread screening and diagnostic difficulties, obtaining precise epidemiological data remains a challenge. The signs and symptoms of DSD can vary but often significantly impact quality of life. Common symptoms include urinary frequency and urgency, a feeling of incomplete bladder emptying, and difficulty initiating urination. Urinary incontinence, both urge incontinence and overflow incontinence, is also frequent. Recurrent urinary tract infections are a common complication. In severe cases, kidney damage from backflow can manifest as flank pain, fever, and other signs of renal dysfunction. The insidious nature of DSD means that symptoms may gradually worsen over time, often leading to delayed diagnosis. Diagnosing DSD requires a comprehensive approach. A detailed medical history and physical exam are the first steps. Urodynamic testing is the gold standard for diagnosis. This test measures bladder pressure and urine flow during filling and voiding, identifying the characteristic dyssynergic pattern. Electromyography, or EMG, of the sphincter muscles can further confirm the diagnosis. Imaging studies like ultrasound or cystoscopy may be performed to assess the bladder and kidneys for damage or abnormalities. Ruling out other conditions that mimic DSD, such as bladder outlet obstruction, is also crucial. While there aren't strict classifications of DSD, it's often categorized based on the completeness of the sphincter obstruction. Some individuals may have partial relaxation, while others have complete contraction of the sphincter during voiding. The degree of dyssynergia impacts the severity of symptoms and the management strategies employed. Understanding the extent of sphincter involvement guides treatment decisions. Managing DSD aims to reduce bladder pressure, prevent kidney damage, and improve urinary control. Intermittent catheterization is often a cornerstone of treatment, ensuring complete bladder emptying at regular intervals. Medications such as alpha blockers can help relax the sphincter muscle, improving urine flow. Botox injections into the sphincter can provide temporary relief by paralyzing the muscle. In some cases, surgical options like sphincterotomy, a surgical incision of the sphincter, may be considered as a last resort. Bladder augmentation, increasing bladder capacity, may be needed in severe cases. Regular monitoring of kidney function is essential to detect and address any complications early on. Lifestyle modifications, such as timed voiding and fluid management, can also play a supportive role. Preventing DSD primarily focuses on minimizing the risk of neurological damage. Strategies include promoting safe driving practices to prevent spinal cord injuries, managing chronic conditions like multiple sclerosis, and providing appropriate prenatal care to reduce the risk of congenital neurological conditions. Early diagnosis and management of neurological conditions are also key to slowing the progression of potential bladder dysfunction. The prognosis for individuals with DSD varies depending on the underlying cause, the severity of the condition, and the effectiveness of treatment. With proper management, many individuals can maintain stable kidney function and improve their quality of life. However, untreated DSD can lead to serious complications, including kidney failure. Recent research focuses on developing more targeted medications to relax the sphincter and improve bladder control, emerging therapies such as neuromodulation, which involves stimulating nerves to improve bladder function, are also being investigated. Future advances may involve regenerative medicine approaches to repair damaged nerve pathways. Continuous research efforts are aimed at improving the long-term outcomes for individuals with DSD.